John and his work is that he's been a PI or co-PI of the Ohio Regional TBI Model System grant for at least since 1997 all the way to current. He's also on the board of directors for the Brain Injury Association of America, and has authored over 185 papers and has brought in about $35 million of extramural funding to the university, and has received many awards, including awards from the Brain Injury Association of America and the American Congress of Rehabilitation Medicine. And he's probably Ohio's expert on brain injury. So we're really glad to have him here and to tell us a little about his recent work. So thank you, John, for joining us today.
Well, thank you, John, and thank you for that generous introduction. As we were just speaking before we started, I have very much enjoyed what the chronic brain injury discovery theme has brought and is facilitating here at Ohio State. So it's really a lot of fun to be part of a much larger enterprise. And thank you, John and Kedar, for that work. So my talk today is the public health burden of traumatic brain injury, and it has a subtitle, and that's is this a 1% or 10% problem? And you'll see when we come back to circle back at the end why that subtitle. I have no disclosures. I will be talking some about the OSU TBI identification method, which with Jennifer Bogner we developed here, but everything about that instrument, its use, its training in it, its reproduction is free. So there's no commercial interest. This is the required accreditation statement. This is this talk has been approved for 1 AMA Category 1 credit. There are the general educational objectives for the Buckeye Neurotrauma lecture series. Planning committee has no disclosures, and you'll receive an email at the end for your evaluation so you can claim your CMEs. What I'm going to talk about today is cover 3 things. The first is I'm going to describe the basis for current estimates of the public health burden of traumatic brain injury. That'll be followed by then looking at some population-based studies that suggest the consequences are more than we've estimated because of there being more essentially prevalent cases. And then finally, I'm going to share some thinking that I've been doing and with colleagues, kind of reconceptualizing how we're looking at the public health burden into an exposure model. But first, an apology. I am talking about public health burden, and some have noted that this phrase kind of suggests that mishap or that's happened to a person is somehow a burden to society. I don't think that's how it's meant, but I understand that sentiment, particularly when in talking about the public health burden, we equate living with disability to premature death. And that is certainly a kind of shallow understanding of the disability experience. And thus, I think an apology for this way of talking about it, which is how we talk about it, is necessary. So this is a graphic of the world burden of disease using disability-adjusted life years, which I'm going to define in a moment, over the last 30 years. And you see up here, injuries is the gray at the top, somewhere around 10% or so. Pretty stable over that 30-year period, while communicable and non-communicable diseases have changed in their relative prevalence. The disability-adjusted life year that was represented there and is represented here as well is a relatively simple statistic. It is the combination of years of life lost, essentially premature mortality, and years lived with disability, and thus my earlier comment and apology. Here you see injury in the lower right-hand corner. When we talk about generally all causes of global burden of disease, injury is represented by the mechanisms of injury, not by what the injury causes, which is one way in which, I think there's a minimization of certain of the causes of injury, like traumatic brain injury. However, when we look at within neurologic conditions, we can see the specific effects of injury. This is for 2016, the global daily disability adjusted life years, just for males, to fit it on this page, by age. And if you look down here, you kind of first pick up this shade of brown, that's traumatic brain injury. And you can kind of see it going across the age groups. A pretty small sliver. You can see why things like Alzheimer's disease over here in light blue, or stroke up here in dark blue, are considered, to be perhaps more important neurologic conditions when you think about, the people being affected, and this way of thinking about looking at the public health burden. However, what if this is not an accurate depiction? What if this isn't the proportionate makeup of the public health burden of neurologic conditions? Now that's what I'm going to spend just a few minutes on here, is kind of pulling apart that disability adjusted life year. First, looking at the years of life lost due to TBI or premature mortality. So premature mortality is essentially starts with the incidence of traumatic brain injury. This is the injury, the TBI triangle that CDC publishes periodically, looking at, essentially medically attended traumatic brain injuries. And it's the deaths shown here at the top, based on 2013, some 56,000, that are used to then calculate premature mortality, or years of life lost. So these are the deaths that happen at the time of traumatic brain injury. But what if there are deaths that are attributable to traumatic brain injury but don't happen immediately? We did a study in the TBI model systems a few years back, looking at one of several studies looking at life expectancy. In this case, we were then using it to make population-based estimates of life expectancy for those who receive inpatient rehabilitation in the US for a primary diagnosis of traumatic brain injury. I should add, and were 16 years of age or older at time of injury. This is what the TBI model systems national database, the population that is studied. And we had some 7,300 participants. They were weighted to some 156,000 individuals in the US who received inpatient rehab for TBI. And then we used two different time points, looking at the mortality rates for similarly age, gender, and racial ethnic groups to compare to the mortality of this population. And kind of cutting to the chase, what we found is a standardized mortality ratio of some 2.25 times more likely to die among adjusted for age, sex, and race, ethnicity amongst those individuals who had had inpatient rehab for TBI. If you survived a year, it still was increased by some 50%. So that standardized mortality ratio is essentially this, showing us the same picture as excess mortality that goes into years of life lost. If you looked at the age at injury, the standardized mortality ratio or excess mortality is greater in the younger age groups. Obviously, because of more years from their expected, their life expectancy, or the lower death rate of peers. The only age group that didn't have excess mortality were those 85 and older, and oddly, there was actually something protective about being injured at that age. But my point here is that none of this excess mortality would be included in the years of life lost that goes into calculating the public health burden. If you look at cause of death, in here it's sorted by the largest standardized mortality ratio, so meaning the greatest association of having had that traumatic brain injury with various causes of death. And you can see it's quite varied, quite a few different causes. And again, only some of these might be attributed to traumatic brain injury. In no cases would have the injury that got them into the TBI model systems national database been attributed as the source of death, obviously. But if a later fall involved the head, or homicide involved a blow to the head, or the vehicular accident, or suicide involved the head, it might be that some of those would be attributed to the years of life lost. But the point is, the vast majority of deaths here are not calculated into the public health burden of traumatic brain injury. Now, if you were listening to Dr. Bogner lecture earlier this fall, you know that that's a select subgroup. That's people whose injury was severe enough that it required them to go to inpatient rehabilitation essentially immediately after their acute care. But this phenomenon of excess mortality is not limited to just the moderate and severe traumatic brain injury. This study from Tom McMillan and colleagues in Glasgow looked at the 15 years following a mild or traumatic brain injury or head injury, as he said, and looked after the injury, looked out 15 years at the rates of mortality per 1,000 for two age groups, those less than 55, those more than 55. And he compared the mild TBI group to those with some other injury, not traumatic brain injury, usually orthopedic, as well as a community control. And if you see there for those under 55, the mortality rate is 4 times in excess of 4 times that of the community controls, and almost double that for the other injury control. For those over age 55, there's a very slight overlap in the confidence intervals between the mild TBI and the other injury control, but definitely some 1/3 greater likelihood of death after mild TBI when compared to the community control. So this isn't just a phenomenon of moderate and severe traumatic brain injury, is the point here. This is also a phenomenon in mild traumatic brain injury. So just to recap that, the years of life lost that goes into that disability adjusted life years, it is in all likelihood underestimating the actual effects of traumatic brain injury, and as a result, underestimating the total burden. So what about years of life lived with disability, the other part of the equation? At the root of that calculation is what is the prevalence of disability due to TBI? And that's really the starting point for coming up within the years of life lived. Once again, we start with the CDC injury triangle, TBI triangle, and in what they're attempted to do is take a given year and then project out the prevalence over all years based on a given year or 2-year period. So that was done. CDC did this twice, two different studies, two different states. In both cases, they were population-based studies, but looked at Colorado and South Carolina. And what they did in those states is they took people hospitalized, so just this part of the triangle, and followed up with them 1 year later. And if there was sufficient impairment still, then they concluded that that person was living with disability. Now, there are lots of assumptions go into that. And their starting point also not only is limited by it being just hospitalizations, but there were no children. So nobody under age 16 in these estimates. And then, of course, we know that the injury triangle may look a bit more like this. So the starting point for estimates of the prevalence of disability due to TBI is this little piece of the injury triangle. In addition, starting from a small point, they use the 1 year outcomes, as the basis for saying somebody would have a disability. That essentially was only catching those whose disability or level of impairment was an immediate result of the injury they experienced. So when they did it in 1996 in Colorado, the estimate was 2% of the general population are living with disability due to TBI. When they repeated that in 2005 in South Carolina, the estimate was 1.1%. Interestingly, this decline, or almost coming up with almost half the rate, was not due to the rate of individuals who were found to have sufficient impairment 1 year post-injury that they were considered to have a disability. The difference was that between 1996 and 2005, we realized that there was a diminished mortality or diminished life expectancy as a result of traumatic brain injury. And this entire difference is due almost exclusively to changes in assumptions about the life expectancy, not in the changes in assumption about the percentage of individuals who will be living with disability. That 1.1% estimate from 2005 has then had a life of its own. It has not only been used pretty much ever since as the estimate in the US for the prevalence of disability due to TBI, but it's been used globally, that where there is not another basis for estimation, this 1.1% is being used for the calculations for disability adjusted life years. As a result, it's not uncommon to see a graph like this that's looking at different neurologic conditions. And in this case, not necessarily just disability. This is presenting percent of the adult population living with the condition. And you can see that this 1.1% is based on that 2005 study from CDC. So I think there is some chance, and as we'll see, I think greater than some, that these projected rates underestimate definitely underestimate the number of people who are living with the effects of traumatic brain injury, and probably even the number of people whose effects, their impairments are so great that it is disabling. And that point kind of raised the larger issue for me, and that is, what if indeed the greatest effects, or maybe it doesn't have to be the greatest effects, just a good portion of the effects of traumatic brain injury are not apparent immediately, but become apparent in time and result in premature mortality or disability or other negative consequences. Then, if so, then we would know for sure that we have a very limited estimate of the public health burden of traumatic brain injury. And it was that thinking that kind of led me and with some colleagues to kind of saying, well, what about thinking about exposure to traumatic brain injury, specifically lifetime exposure to traumatic brain injury, as the lens through which we try to estimate the public health burden of traumatic brain injury. And I will tell you that the thought came reading an introductory chapter in an epidemiology textbook about toxic exposure. And what I realized as I was reading that if TBI was a chemical, these are the kind of questions we'd be asking. So what's the relationship between the dose of the exposure and the effect on the person? Can there be cumulative effects of repeated exposures or persistent exposure? How does the age of the host interact with both the exposure and the manifestation of the effect? Thinking about lead, for instance, and how early lead exposure is not often, effects are not seen till later. Of course, there were other questions and more nuanced and subtle questions in this. But this was my takeaway, that we would be, if TBI was chemical, we'd have a whole different way of thinking about it. And to me, that this conceptualization kind of reframes some of the questions. How does the magnitude of altered consciousness affect later consequences? So essentially, severity as dose. This is probably the thing we've studied the most, but we tend to study it in relationship to an index injury, into a single injury, not thinking about the relationship of that injury to other traumatic brain injuries that a person may have had in their life. How many TBIs has a person had, and what was their timing? So essentially the cumulative effect, like in toxic exposure, being about the number and spacing of one's lifetime traumatic brain injuries. How old was the person when the TBI occurred, when their first occurred, when the most recent occurred? Essentially the developmental interaction. So these kind of questions, the way we had been studying traumatic brain injury for a long time, which was to pick folks up at the time of some index injury, look at them soon after, or even a time after, but kind of using the index injury as our starting point and not thinking about prior injury, and sometimes not even thinking about later injury. However, that some developments, some new tools, including the OSU TBI identification method, gave us an opportunity to take this broader look at lifetime TBI and ask some questions about exposure. Early on, in at least 3 states, there were adaptations, or the actual OSU TBI ID was used, or it was adapted in Ohio and North Carolina for their behavioral risk factor surveillance system that's conducted by the Departments of Health in each place. And population-based surveys were conducted so that we could look at, what is the prevalence in the adult population, general population, of various characteristics of lifetime history. So just looking at these 3 states, Colorado was actually the only one that had enough time given to the interview to know any traumatic brain injury, and a surprising 42%. I will say to you that in Ohio, we have since been able to also look at any traumatic brain injury. We're not getting rates quite that high. But maybe a little bit more consistent indicator are the percentage of adults who've had at least one TBI that involve loss of consciousness. And as you know, one does not have to lose consciousness to have a traumatic brain injury, but you have probably had a little bit more severe one if you have lost consciousness. And here in the 3 states for the general population, it's a much more consistent estimate. Some 1 in 5 to 1 in 4. What percent then have had a moderate or severe traumatic brain injury? A little bit more variability here, but not a lot actually. And our more recent estimates in Ohio actually are up around 3.2%. So there's some relative consistency here. And one of the things that we've posited is that if you've had even one moderate or severe traumatic brain injury in your life, there is probably some likelihood that today you are still experiencing some consequences of that. May not be disability, certainly may not be disability. May not be even something that you wouldn't see from a galloping horse, as George Pricatano used to say, but it might be something that in neuropsychological testing or in other more discrete ways of assessment, we would still see that there's some cognitive impairment, there's some kind of neurobehavioral impairment. Similarly, we posited that if you had a TBI with loss of consciousness, not any TBI, but one that involved loss of consciousness before the age of 15, there would also might be some likelihood that you today are still experiencing some effects of that. And you're going to see some of the research that was behind that hypothesis. But given those two characteristics of one's lifetime exposure for at least two of the states, and I should have mentioned that in North Carolina, they cut it at 18, not 15. That's why that one may be a little bit larger. But for two of the states, we could look at, okay, in the adult population, how many people have had one or the other of these, or both? They had loss of consciousness before age 15, or they've had a moderate or severe traumatic brain injury. And there, the estimate is, pretty consistent that, you might say 11%, of the adult population have enough of a history that it could be reasonable to suspect that they are experiencing some effects, some consequences today. So hold on to that 11% number because we're going to come back to it. So what about these consequences? And, I recognize that what I'm showing you is not, definitive proof of the, utility of an exposure approach, but I'm trying to do some sampling here of some of the reasons why we think this could be a way to go forward. So what about consequences? In the province of Ontario, as well as in Ohio and Colorado, there have been a series of studies done actually where we've looked at what these consequences are. Now in Ontario, they used a question that asked if you've had a TBI with at least 5 minutes loss of consciousness or a hospital stay. So a little bit different than what we've been looking at with just loss of consciousness. But there's some consistency. And of course, these were adjusted for sex, age, and education. One of the things that has been found consistently is there's a relationship with addictive type behaviors. There is a relationship with psychological distress and mental health problems. There's a relationship with cognitive functioning, as you might expect. In this case, a overlap with diagnosis of attention deficit. And in Ontario, rather uniquely, they've looked at motor vehicle crashes, but particularly driver aggression. And there's a shockingly 4 times greater likelihood of having engaged in some kind of driver aggression in the last 12 months if you had a prior history preceding that 12 months, by the way, of at least 5 minutes loss of consciousness. And so one of the other themes that taps into is a tendency towards violence or disinhibited behavior. In Colorado, some similar trends, lower life satisfaction, more physical problems here, noted in both dizziness and balance. Again, this is adjusted rates. more concentration and memory, the cognitive aspect that we would expect, but an effect on general health. And that's one of the other themes that has emerged, is that, this is not just a cognitive problem. It's not just a neurobehavioral problem, that there is an impact on general health, including the likelihood of having disabilities. 2.25 times more likely to currently have a disability if one had prior history. I think I neglected to say before we started, of course, these relationships are associations. They are not causal, but we'll come back to that in a moment. In Ohio, finally, some of the same themes have emerged. We see greater drinking and cigarette smoking. We see a definite effect in terms of mental health. We've seen various health aspects, from one's overall general health to sleeping fewer than 7 hours a night, and twice as likely to be diagnosed with a chronic condition. And as you might suspect as well, like in Colorado, a 2.5 times greater likelihood that you also report that you have a disability. Now, again, this is not causal. These are associations, but the point, this is, I guess I would say, this is at least smoke for that may be there for a fire that is a relationship of earlier exposure to these later consequences. What about severity as dose? We definitely have been studying it, but not in terms of lifetime, as I said before. But we do have some studies that have looked at one's worst TBI and then the likelihood of the current impairment or problem. So these are the same data we were just looking at for Colorado, but now broken down by the severity of one's worst traumatic brain injury in their lifetime. And the key here, I think, is the monotonic relationships we're seeing. So while the method doesn't allow, only allows us to conclude association, when you're thinking about causality in general, the presence of a monotonic relationship is one of the clues that you may have a causal relationship. So here we're seeing imbalance, memory, concentration, activity limitations, poor physical health, not quite as stepwise as some of the others, but a pretty consistent set of patterns. The Ohio data showed something similar. Now here we've cut severity a little different way. The blue is a mild TBI with less than 5 minutes loss of consciousness. So definitely loss of consciousness, but less than 5 minutes. Then the red bar is still a mild TBI, but it's 5 to 30 minutes loss of consciousness. And the green bar is a moderate or severe, meaning 30 minutes or more loss of consciousness. And while these are not quite as pretty, although it is here for the diagnosed with a chronic health condition, but not quite as pretty in terms of a monotonic relationship, we're still seeing this stepwise kind of greater association with greater severity of one's worst lifetime injury. And some places where it didn't quite pan out, heavy drinking past month, that is not a significant relationship. We know there is a protective factor for more severe traumatic brain injury because of likelihood of seizure disorder, or maybe being limited in the ability to get drink. Maybe you're back living with a parent, for instance, where it's being limited. But again, and here for depression in one's lifetime, a very distinct monotonic relationship. So dose or severity of one's worst TBI, does seem to have some promise in terms of predicting the lifetime later consequences. And certainly the associations are more likely, if not cause, the potential that there's some cause there with more severe TBIs. Not earth-shaking, but again, the difference in the exposure view here is that we're not just taking the index injury we are thinking about one's whole lifetime and their worst exposure, their greatest severity. How about developmental contributions? Do childhood TBIs, is the one that we've looked at the most, even if mild, have adult consequences? And the attention to this question really started with some work that Audrey McKinley from Christchurch, New Zealand, published first in 2008 based on the Christchurch birth cohort there. This cohort used medical records and from hospitals and physicians, emergency departments, to prospectively identify traumatic brain injuries experienced by these some 1,200 children born in 1977 in Christchurch. So these were medically verified traumatic brain injuries. What she was able to analyze then were three subgroups. One group of no medically verified traumatic brain injury, and that was thankfully the largest. There was another group that had a apparently mild traumatic brain injury that had only been treated outpatient. There was no inpatient treatment. And then a third group, and the smallest, again, thankfully, was a group of children who's had a mild traumatic brain injury, but with at least one overnight stay. If they had more than two night stay, then they were not included in that group. And if they had a documented moderate or severe traumatic brain injury, they were not included in that group. And that was the smallest group, and actually too small to use in further analysis. So what Audrey had was a group with no TBI, a group with mild TBI, but only outpatient medical attention, and a group with mild TBI and a brief hospital stay. And when she looked at, then followed up in late adolescence and early adulthood, what she found was that, for instance, the group that had hospitalized with a first mild TBI before age 6 were 3 times more likely to have a diagnosis of either alcohol or drug dependence by age 25. There was also a group that were first hospitalized with TBI in adolescence, and they were 3 times more likely to be diagnosed with drug dependence. She also found a definite association with worse TBI and likelihood of arrest, shown here that the red bar are the mild TBI inpatient with brief inpatient stay, the blue being the outpatient, and the green, the reference population, are those children who had no medically attended traumatic brain injury. And all of these differences, are statistically significant, and you can see quite pronounced. And it was this work, this looking at these first TBIs before age 6, that led us to really start saying, wow, this early experience may be something important for understanding, not just adult function, but later adult traumatic brain injury. And that thinking was behind then a study we did in the TBI model systems, where using the OSU TBI ID, we looked back and said, okay, you got into the model systems, based on this injury that just happened, but what injuries have you had before? And here you see those in the red bar is those with no prior traumatic brain injury, and those who had a previous traumatic brain injury, again, before age 6, we were mimicking the McKinley breakdown of age at first here. And what you definitely see in terms of coming to the injury with an alcohol misuse problem, that early injury group were significantly more likely than for sure the no pre-injury group to have misused alcohol prior to their index injury. Not different in many ways from what Audrey was finding in the Christchurch birth cohort. Some other pre-injury issues that this population had they ever received mental health treatment? Once again, you see that before age 6 group appearing to stand out, but almost all of the prior TBI groups having a higher percentages than those with no prior. For felony incarceration, it was a little bit later. It wasn't the youngest, but it was the adolescents, and preteens, well, the 6 and older, basically. And this work was the what was behind when we first started looking at injuries before age 15 and injuries after age 15. And as we'll see in a moment, maybe a bit prematurely deciding on those cut points. A little more recently, the Avon longitudinal study is following 11,400 children in southwest region of the UK. They have 800 with mild TBIs, 2,300 orthopedic controls, and then some 8,300 that are neither. So far, they've only reported at essentially substance use and psychiatric comorbidities, as well as juvenile involvement with the justice system at age 17. We haven't seen later than that. But what's nice about this cohort is that they can control for pre-birth complications, adverse childhood experiences, as well as certain parental characteristics, including socioeconomic status. And the results of that suggest that I could do this better, apologies, but essentially this blue bar here is comparing the TBI group to the no injury group. And in each case, there's a significantly increased risk. But maybe it's not the TBI that's predisposing the person to alcohol or cannabis or tobacco use. Maybe it's a personality approach, like impulsiveness, that in some kids is going to result in an orthopedic injury, but in others a TBI. So that's why we include these orthopedic controls. And what you see here, though, even so, for alcohol, the TBI group is more likely to be having alcohol problems at age 17 than the ortho group. For these other comparisons, the ortho for cannabis and tobacco, the ortho and the TBI groups are not different. You can see that there's been kind of a heavy focus on addiction or substance misuse in this work, looking at early TBI and adult consequences. And of course, in this case, we don't really know adult consequences. These are 17-year-olds. Oops, and to point that out to you. A study that we just completed here based on several years of Ohio's BRFIS data, and it took several years to have enough of an N. And what we asked was, is binge drinking in adulthood related to age at first TBI? And here is any TBI on the left, and here on the right is only those who've had no worse than a mild TBI in their lifetime. And what you see, the red bars, those whose injury occurred after age 20, and that there is elevated risk for before age 20, particularly in this 10 to 14 and 15 to 19-year-old groups. And as a matter of fact, and this is just a little on the wonky side, we had done this comparison with just 1 year's worth of data a few years earlier, but we had cut it at age 15 right here. And what you see is that if you use before 15 and after 15, you're not going to see a difference. And we didn't then. It's only when we had enough of a sample to be able to look more discreetly at these age brackets that we definitely saw that this adolescent group is at greater risk of adult binging given an early childhood TBI, even if mild. So like I said, lots of emphasis on addiction, but not only on addiction. And one last study here looking at adult consequences of childhood injury, the largest, this is from the population registry in Sweden, 1 million Swedish citizens, So they looked at whether they had a medically treated TBI, had to be a diagnosis in the health record before age 25. And then essentially they had about 10 years after that to look at what kinds of consequences there had been. They compared those individuals up to age 25 who'd had a TBI with the general population. They also compared them with siblings who had not had a TBI, and there was even an orthopedic control. Additionally, they had quite a bit of information about family and parental characteristics that they were able to control for. The kinds of outcomes they looked at or consequences were, psychiatric again, but they also looked at premature mortality, disability from work, receiving welfare benefits, or low educational attainment, meaning given their age, had they completed as much education as one would expect. And if overall, just looking at the sex and epoch, what period of time they lived in for these various outcomes, you see these are all statistically significant. There is definitely elevated risk of having had that traumatic brain injury. If you control then for socioeconomic status as well as some characteristics of the parental history, it's attenuated some, but there still remains statistically significant increased risk for all 6 of these consequences. And then adding in an uninjured sibling, which is kind of a very cool way of controlling for all the issues in the household, it actually doesn't attenuate the relationships much further, a little bit in a couple cases. But this is probably one of our most controlled looks at, is it the TBI or something else that's this early life TBI that's responsible for these adult consequences. Now, given the size of this, the other thing that they were able to do is look at the age at first injury, which had become an interest because of kind of the one set of findings in some of the Christchurch and our model systems findings suggesting these youngest kids are the most vulnerable, while others suggesting that maybe it's a little later into preteen and adolescence and even young adulthood. What you can see here for these, just adjusted for demographics relationships is that as the age at first injury increases, so does the risk. So they were definitely finding it's in adolescence and later that it's even more than at those early age groups. But once they started to control, and I just kind of jumped ahead to putting in all the controls, including siblings, some of the risk goes away for this early age group, and even the next, up through age 10. But it pretty much remains for the teens and young adults. And what we think is that it takes a little bit of to wrap your head around this, but we think this comes down to is that essentially a good home environment can mitigate the effects of an earlier life traumatic brain injury. If it's a bad home environment, then both you and your sibling may be predestined to some of these negative outcomes. But a good home environment may mitigate the additional risk of the traumatic brain injury. But even a good home environment is not mitigating the risk when the injury occurs in adolescence or later. Maybe that's just not having the same opportunity. Maybe it's developmental stage and kind of where the brain's at, or probably most likely it's both. When you limit this just to mild TBIs, you take out all the more severe, it does remove the risk of mortality. That might be expected, and that's good. But you still end up with a lot of risk, even of these mild TBIs that are occurring in adolescence and young adulthood. So the point here is that, I think we have smoke, if not fire, to suggest that childhood TBIs, even if mild, may have adult consequences. Certainly in the addiction area, looks like there's some likelihood, but it may not be limited to addiction. So just coming back to our exposure then model, there's a lot that we haven't, I haven't even touched on here. So I just looked at children. What about middle age? There's definitely some suggestion that a traumatic brain injury, even if mild and experienced by an older adult, may be sentinel in terms of triggering the development of loss of independence and other kind of and medical conditions. We haven't really begun to touch that yet. The cumulative effects is very hard to study, and one needs very, very large samples to get at it. And so we really are just scratching the surface here in terms of number or timing that may be associated, as with lead poisoning, with the later effect of it. And related, what about when you combine a traumatic brain injury with some other source of brain compromise, like anoxia or stroke? What's the interaction of those? So much we haven't looked at yet in through this exposure lens. So let me just wrap up here by saying that, there do seem to be significant associations, at least with, some hint of causality between lifetime history of TBI and various health and social consequences. We think that those associations at least support trying an exposure lens and exposure approach then to looking at the public health burden of traumatic brain injury. And what that means is that we're not going to limit ourselves just to identifying, TBIs immediately, death immediately, or disability that is immediate and persists, immediate as in year one and is persists, that we're going to widen the consideration to delayed sources of mortality, delayed sources of disability, or other consequences. We have a lot to learn if we're going to take that approach. It certainly seems like mortality is being underestimated, if not disability, due to TBI. And just to kind of put a fine point on it, here's that graph again, the 1.1% traumatic brain injury. But what if that 11% number that I threw out earlier, were actually the case? Then we'd be looking at a graph like this. And what spurs my emotions are, what would be the distribution of federal funding for research if this were the accepted picture of the percent of the adult population living with traumatic brain injury versus this being the current thought. So with that, I want to thank you for your attention this morning. I think I may have left just a couple minutes for questions.
Thank you, John. That was excellent information as always. And we'll open it up for questions. I'd like to start. One of the things that interested me about the data sets that you showed, one is that last point about the 10 or 11%, that's striking. Now, what about in the context of the young injuries and looking at disability and functional recovery? The 0 to 4 age group is interesting. And I think from a neuroscience perspective is it because there's just more brain plasticity and maybe more potential for repair? I know you attribute it to a home life, but I think of it kind of in a neurodevelopment sort of way. I wondered if you had thought about it the same.
So yeah, I may have overemphasized the home life effect. There's been that debate for some time in pediatric traumatic brain injury. Is there so much plasticity that the young child recovers immensely? And when you work clinically in that field, you see these incredible, they're just little miracles. It's like, wow, could that be the child 1 year later that I saw in that in that bed unconscious. But what we also know from the pediatric brain injury literature, and this does tend to be the more severe injuries, that sometimes developmentally that child with an early childhood injury hits adolescence and they just don't make some of the developmental advances that their colleagues do. And so it's been called, falling off the cliff. But I think absolutely there is if I didn't make the case that if I seem to not be making the case that there's both a brain, a biologic developmental, effect here going on with an environmental effect. I think it's probably both. And probably the environment is just the ability of the environment to make a correction, in the biological development to allow that kid to catch up, essentially.
And do you have enough data from those data sets to parse out male versus female? Because I know I've read some articles, especially with sports injuries, about kind of a longer recovery time in females versus males, and I wonder if you were able to see any of that in those data sets. So
that finding from sports and concussion more generally, is maybe attributed in part to how symptom reporting is different for males and females. So I don't think we even know that for sure. Okay. In that literature. There is not a lot of evidence of differential recovery in that youngest group based on sex. There is some, however, indication that there may be sex differences based on juvenile injuries, and just the ends are not sufficient. That's some work that Zach Weil, who was here, has done.
Cool. And then I guess one last thing. Kadar, does anyone have their hand raised? You guys are free to raise your hand and ask in person. We enjoy that type of question and answer, but you can also just write into the chat as well.
Yeah, I'm not seeing any yet, John.
Okay, well then I'll take this opportunity to ask another one, and that is, we often hear about the link between brain injury and then later life. Alzheimer's or CTE, and that was one of the figures you had on there. That was a 2.4% dementias associated with disability and mortality. Now, some of those individuals probably have a history of head injury too. So TBI not only maybe 11% up there, you might have some of that even bleeding into your dementia scores too.
Yeah, absolutely. And if the database is large enough and the health recordings are good, the health data in it is good enough. We've seen a lot of this out of the VA, but it's also coming from the Scandinavian population registries. There definitely seems to be a relationship between earlier life traumatic brain injury and later life dementia. Now, it is not the only factor, and but it is a factor. Early, when we look specifically at Alzheimer's, it looked like what the Alzheimer's effect might be were a little bit later life TBI. So it might have even been, prodromal. It might have been things were starting to change. They fell, hit their head, and then 5 years later, they were actually diagnosed with Alzheimer's.
So like an accelerator.
Yeah. Or a marker, just a marker that things were starting to go bad, either one or both. But when you broaden it to dementia more broadly, there's no question that it's an earlier life TBI carries some risk factors.
Yeah, and I think that's one of the foundations of the chronic brain injury program is that idea, the lifespan and later life, and that's why we call ourselves chronic brain injury, and we get into the aging spectrum and also the dementia neurodegeneration spectrum too. Okay. Let's see, we're seeing, Michelle Basso, great. We have a question from Michelle.
Hey, John, can you guys hear me?
Yes,
absolutely.
Hi, Michelle.
Yes. Fantastic talk, John. That was so interesting. This is kind of an interpretation question, really, and really I'm asking you to theorize here or just share your knowledge about this. I think this long view of early events is really important, and it's something that we miss, and so that your talk is really bringing that out. The challenge that I have is, and I'm wondering how you do deal with that or how you factor that into your interpretation, is the change in medical treatment over that long time span. You know, we're definitely better at treating these mild cases, at even knowing about the mild cases, than we ever were. And your data is embedded in your data are, you know, not necessarily the best practices or identifying these things. So how do you factor that into these risk factors and odds ratios? How do you think about that?
I think definitely when we're looking at some of the U.S. data, particularly those retrospective ones, that it's error variance. In other words, we're not, and it's there's something there, and we're just not picking up on it. In some of the population registries out of Scandinavia, where they've had better healthcare, though maybe not knowledge of concussion, as long that may be a bit less of a factor. But there are some different, really interesting historical cohort factors or confounds that I don't think we're at the bottom of. One that has intrigued me is that older adults consistently report lower prevalence of lifetime history. And we thought, okay, that's memory, but it doesn't. It's not gradual with age. It's not. You don't see a gradual effect of it. And this was in some of our early work, and I looked back to looked at how old those people were and kind of when they lived, when their childhood was. And in the U.S., we didn't start doing organized sports until the later 60s. Mid to later 60s. And these older adults had not had a childhood where they was full of much more than maybe Little League. It is possible. And where you see the real difference in reporting is very, very mild traumatic brain injuries. And it's possible maybe they missed some of those childhood injuries, or it's possible they're not remembering. But that's all. I brought up a different issue to just make to answer your question, that I think there are cohort or historical cohort confounds that we don't fully understand yet.
Thanks.
Any more questions before we let everybody go for
Yep. We have one in the Q&A. So Charlotte
Okay.
said, thank you for a very interesting talk. In regards to connections between TBI and other injury or disability, do you have any insight into whether COVID might more seriously affect those who have had a TBI, given its ability to cause neurological symptoms?
So, I think we would have to, start with that's definitely a good question to ask. I think there's some indication that it's so. We know that socially it has had a problem. There are social factors of the greater isolation that we just both anecdotally, and now there are some studies suggesting that persons with traumatic brain injury were more affected by that, had greater depression, greater distress as a result of that isolation. We also know that there seemed that for some subgroups, there was an increased anxiety associated with the COVID period, as well as an increased amount of alcohol consumption. It's a nuanced finding. It's like just more drinks per sitting, but not necessarily more problematic or more binging, for instance. So there are social factors there. But I think, to whatever extent we think COVID can affect, the respiratory system, which then might, have an hypoxic effect or have direct effects on the central nervous system, which there's some indication it could be, then we should be alert to it interacting with this other source of CNS compromise. Because I think it's pretty clear that when we put two loads on the brain, we get more of an effect than if we just put one load.
Okay. Well, excellent talk, John. Really, really informative. Enjoyed it. And, thank everybody for attending this Buckeye Neurotrauma lecture series. And everybody have a great weekend. It looks like we'll have some nice weather. And everybody have a happy Thanksgiving. So
Thanksgiving. Thanks for the
Yeah.
invite to do this. Appreciate it.
take care, everybody.
Take care,
Thank
John.
you.